everybody. Thank you, Dr. Bakri, for the nice introduction. You talk about me, but I know a lot of people here in the conference here. There's nephrologist and endocrinologist there, so it's very difficult to discuss these topics in the attendance of nephrologists and diabetologists in the conference. But Dr. Bakri, to answer your question, we have to go back to our practice and our concept of understanding the chronic kidney disease. And it's very important for all the physicians as internists to differentiate between kidney function test and kidney damage test. And this is very important because all the studies now, if you look at the graph here, that the kidney function test is good for a long time. At the same time, you have people who has yes. You have people who has like kidney injury, and if you just check the GFR, you are missing those people. And if you look at the graph here, if there's any pointer, if you look at the graph here, it's very good GFR. It's between 100 to 130 almost for good years. But the albumin creatinine ratio, which represents the kidney damage test, it's starting very earlier. So if you depend only on GFR, you might miss early kidney damage test. And you will not see the difference in the GFR till you have like 20% or maybe 30% of the kidney damaged before you see it. And as we know that the guidelines, they divided the albumin creatinine ratio to A1, A2, and A3. And we used to say less than 30 is normal, above 30 is not normal. Now it's not like this. When they talk about A1, they say it's normal or mildly elevated albumin creatinine ratio. Yes? This is the pointer? No. It's fine. Okay, thank you. And this is to move in and out. Okay, so. And that's why now when you see that the deviation that they said A1 is normal to mildly elevated, that's because the evidence is very strong now that the cardiovascular risk increase from A1C from the albumin creatinine ratio of 10, not only 30. So that's why it's very important to check the kidney damage test before you decide about your patient treatment. And this is very important because if we look at the people who has chronic kidney disease with diabetes and compare them with people who doesn't have diabetes, there is like two-fold increase in the case of MIs, five-fold increase in the CHF, 3 to 6-fold increase in hospitalization for heart failure, and 3-fold increase in cardiovascular death. And if we look at the people who has type 2 diabetes with and without albuminuria, moderate to highly elevated, there's 2 to 4% increase in the emergency room visits. Hospitalization, there's 4 to 10% increase, and there's 4 to 40% increase in ending to end-stage renal disease and needing dialysis. So early intervention, it helped to protect our patient from cardiovascular risk in diabetes and chronic kidney disease. And what are the guidelines recommending now? Is you need to check the GFR, albumin creatinine ratio at least once a year. There's like heat map, I'm gonna talk about it later, maybe like twice or 3 or 4 times even, depending on the GFR and the A1 albumin ratio. And why they need this? Because that will decrease and help you to stage and treat your patient to protect him from chronic kidney disease progression and to protect him from cardiovascular disease events. And actually, the American Diabetes Association, they went further even. They said if your patient albumin creatinine ratio above 300, your goal is to treat him, to put him on medication to decrease that albumin creatinine ratio to 30% at least. You need to decrease the albumin creatinine ratio to 30% at least to prevent him from the progression of chronic kidney disease. This is a heat map. It's very important. This was done by KDIGO, and it's very important, very nice one. They took GFR in concentration and albumin level. And GFR, we all know there's like 5 levels, G1, G2, 3, A and B, of course, and G4 and G5, and they put albumin ratio here, A1, A2, and 3. And this is the heat map. So if your patient in this area, he has GFR1 and has albumin creatinine ratio in this level, he has very low risk to have chronic kidney disease. But the risk is still there, 3 to 5% in 5 years. And if your patient in the same level of GFR, but he has A2, he's in moderate level. He's in A3, he has high risk. So GFR alone is not enough. So you need both of them, Dr. Bakri. You need the GFR, you need the albumin creatinine ratio to stage your patient, what kind of risk he carries, not only for CKD progression, also for cardiovascular risk. And if you allow me, this helps you to know how frequency to check your patient for his parameters. And if you look here, they put 1 here, 2 here, 3, and 4. So this is the guidelines by KDIGO to check your patient GFR and albumin, and also when to refer your patient to a nephrologist. So to simplify it, if your patient A3, refer him to nephrologist right away. If he's in GFR 4 or 5 level, also you need to refer him to your nephrologist. So, for example, this is like a patient of Dr. Bakri. I get the benefit from Dr. Bakri to present the case here. She is like a 53-year-old female, type 2 diabetes for 7 years, and hypertension for 3 years. Her BMI is 28.3, blood pressure fairly acceptable, and A1C is good. Her electrolytes and blood test echocardiogram normal. For this patient, we need to check the GFR, and the GFR is 93. So where she is, she's on mild or moderate or severe. You cannot tell without albumin creatinine ratio. And when we did the albumin creatinine ratio, she has 320, and she is there. So she is high risk. If she was like less than 30, she will be mild. If she is like between, she will be moderate. So this is very important for us to check A1C, ACR with the GFR when we check for our kidney test. And what our history about treating the kidney or protecting the kidneys in type 2 diabetes. In 1980s, we tell the patient, if you have diabetes, you're going to get chronic kidney disease, but sorry, there is no treatment. In middle 80s, we start to talk about anti-hypertension medication to help the patient to protect his kidneys. Late 80s, we talk about the glycemic control. So we address the 2 common factors, the hemodynamic factors and the glycemic factors. And then 1994 and 2000, we start to say which anti-hypertension medication does better for our patient. ACE in 1994 and 2001, we have the ARBs, and then we kept silent for years, from 2001 till 2019, till the SGLT2 inhibitors come to the market, and they have like 3 studies, CANA, DAPA, and IMBA, and showing the good benefit of adding SGLT2 inhibitors to protect or to slow down the progression of CKD in our patients. And then GLP-1 is like going on, and then finerenone come to the market to address the third forgotten factor which leads to chronic kidney disease progression, which is like inflammation and fibrosis. And now the guidelines, they are talking about 3 pillars approach. Whenever you have patient with type 2 diabetes and chronic kidney disease, you need to address him with 3 pillars approach. You need to have him on RASI treatment. You need SGLT2 inhibitor, but now they are talking about non-steroid MRAs, which is finerenone specifically. And this 3 pillars drug therapy should be combined with controlling of sugar, hyperlipidemia, smoking cessation, hypertension, proper diet, and exercise. So this is the 3 factors we addressed for years, the first 2 factors, the hemodynamic factors and the metabolic factors, but there's like forgotten factors, the inflammatory and fibrosis factor, and we know that from the kidney biopsy, right? When we do kidney biopsy, we see inflammation and we see fibrosis in the pathology. And that's why finerenone came to the market to address these factors. And if we look at the hemodynamics factor, as we said, ARBs was like used to protect the kidney progression to chronic kidney disease years ago, and this is like 2 important familiar studies, the renal study and the IDENT study, renal study, showing the difference between losartan as ARBs and placebo. There is like 16% relative risk reduction in the kidney endpoint, and there's 20% in the IDENT study comparing irbesartan with amlodipine and placebo. But the risk is not zero. After starting, we still have residual risk. We all know that there's a lot of patients with type 2 diabetes and CKD. They are on ARBs, but still they end up with chronic kidney disease, stage 4, and maybe end-stage renal disease and dialysis. And when SGLT2 come to the market, there's 3 studies, as we said. Also, they show good and significant reduction, but still the risk is not zero. It's not complete protection. Still, there's like ongoing fibrosis and inflammation in the kidney, and that's why finerenone came to the market. If you go with
Thank you very much, Bahir. Just we're going a little bit behind on the time. So as you mentioned, now we have almost 4 classes of medication where we can offer our patient to reduce the cardiovascular and progression. So from your practice, and I know you've been using finerenone since it came, so what's unique about finerenone? Why, how can we differentiate? Why should I use finerenone instead of the other if I cannot put the patient on all of them? And what's the extra benefit?
Right.
And if we can go a little bit faster.
Sure, I'll go faster. To answer the question, we need to understand the mechanism of action of finerenone. We all know that we learned from, in the last maybe decade, from the RCTs, that CKD and CHF are chronic inflammatory diseases, not only blood sugar or chronic kidney disease. So in hypertension people who has a CKD, they have overactivation of the MR or the mineralocorticoid receptors. So we thought that this is responsible for the inflammation and the fibrosis we see in the chronic kidney disease. So if we block this MR, we might decrease or slow down the progression of the disease by blocking the inflammation and the fibrosis process in the kidneys, in the heart. We protect our patients. And what's the difference between finerenone and the other in the market? We all know that spironolactone has been there for maybe 80 years or more, and it's good MR, but it's steroidal one. The finerenone is non-steroidal one. By saying non-steroidal one, you know what is the difference. So if you got non-steroidal one, that means he will not have the same side effects of like spironolactone. And if we look at the side effect and the effects, the efficacy and the safety profile of finerenone, it's very effective in the inflammation and fibrosis, greater than spironolactone. The risk of renal electrolyte disturbance is low. Risk of sexual side effects is very important, especially for male. When you give them spironolactone, they suffer from erectile dysfunction, gynecomastia, female from dysmenorrhea, and there is not there with finerenone. Also, the effect on the systolic blood pressure is very moderate, and the most important one is hyperkalemia. It's very moderate hyperkalemia and usually very manageable. You just stop the medication, you get there. And the 2 studies, like to see what the evidence-based medicine of finerenone, there's 2 studies done, Fidelio and Figaro, and they put it together in Fidelity study. It's a pool analysis for those 2 studies. And if we look at the patient involved in these studies, it's from stage 1 to stage 4, and albumin creatinine ratio A1, A2, A3. And the important thing is that 60% or 40% of the people who has albuminuria, they have GFR above 60. So as we said before, it's very important to check the albuminuria with the GFR. And this is the 2 study, as well as the Figaro study. The one, the endpoint was cardiovascular results, and it showed 14% relative risk reduction in the endpoint. And for the hospitalization for heart failure was 22%, which is very important. You need patient to be active in the community. You need patient to spend more time with his family, not to be readmitted to the hospital. And this is very important result. Also, on the other side, Fidelity study showed 23% relative risk reduction in the kidney endpoint, and specifically 20% relative risk reduction in going to end-stage renal disease and dialysis. And if we look at the efficacy of the studies, there is like 32% reduction in ACR in the first 4 months. Remember, like when we talk about the American Diabetic Association recommendation, if your patient has ACR above 30, 300, you need to decrease it, your goal to decrease by 30%. This study is showing 32% within 4 months, and it's sustainable during the whole or throughout the study. It's not like temporary reduction. And for the safety profile, 0.19 millimole increase in the potassium. None of the patients has potassium-related death. It's very safe medication, but still you need to choose your patient. People who get hyperkalemia, usually the people who has like advanced chronic kidney disease, low GFR, high ACR, they are on beta blocker, or to start with high potassium. Those are 4 risk factors. And very if you allow me one word about SGLT2 inhibitor, those people who were involved in the study, 6.7% of them only, they have SGLT2 inhibitor on board. And they look at those 2 arms, people who were on only finerenone and combination of finerenone and SGLT2 inhibitor, and the result was very significant that finerenone decreased the albumin creatinine ratio by 32% alone, in combination 37%. So the major effect was for finerenone.
Okay, thank you. So as you said, it's very important to really bring the proteinuria, and I think you have a case where you're going to show us the difference. So with all this evidence from phase 3, and we've been using finerenone and also in the state even earlier than the UAE. Right. Do we have any real-world data to really reflect this in practice?
Yeah, there is like a very good study done in the United States. It's like database. It's a retrospective longitudinal single-arm study. It's done on patients between July 21 and August 23. That's 2-year study. As we said, a patient who has CKD with type 2 diabetes who were initiated on finerenone during that period of study only. And they look at the comorbidities and the co-medication the patient were using, and their goal was to look at the safety and the efficacy. The efficacy by looking at the ACR level, and the safety by looking at the hyperkalemia incidence. When they talk about the comorbidities, they found out that almost everybody who was involved in this study, he was hypertensive. 30% or 39% they have coronary artery disease, 23% they have CHF, and they look at the doctor's behavior also, and they found out that most of the doctors, they start the patient on finerenone when they are in stage 3 kidney, and the majority of them, they are in A2, A3. There's only few patients in A1 or like stage 2 they were started, which is like not recommended by the guidelines. We'll talk about the guidelines later. And it's not working. And for the co-medication, they find like 50% almost they went on RASI treatment. 38% they were on SGLT2 inhibitor. 25% they were on GLP-1, and 29% they were on insulin. And this is like what happened. For the first time, the index, 85% they were studied on 10 milligram, and 14% they were studied on 20 milligram of finerenone. And after 1 year, only 70%, or like 70% they still on 10 milligram. So there's a problem in titrating up the dose of finerenone from 10 to 20. We need to follow the guidelines when we treat our patient. Yes, it's good to start on finerenone, but it's better to give him the maximum tolerated test or recommended test. And when we look at that safety profile, the hyperkalemia was very low. Only 0.04% they have to be hospitalized for the hyperkalemia. And for the efficacy, there's like 39% decrease in ACR after 4 months, and that was kept after 12 months, it's 41%, so still there. And back to our patient, you saw this patient, her GFR was 93, and her ACR was 320, she has high risk level. She was started on 20 milligram of finerenone, and after 4 months, her ACR was decreased to by 35%, which is very good results.
So I think we're behind on the time, so if you can just quickly review please, the guidelines quickly, and also right away, like how to initiate and titrate.
All the guidelines now, they put finerenone as like treatment of the patient.
I think they cut off.
Yes. all the guidelines now, they put
Can we take 2
finerenone
minutes,
as a
please?
treatment for your patient with a condition that patient GFR should be above 25, and he has albuminuria more than 30, and his potassium is normal. And the starting dose, according to the companies, is you can start at 10 milligram if the GFR is less than 60. You can start at 20 milligram if the GFR above 60. And then you need to check the potassium in 4 weeks. If the potassium still within normal, less than 4.8, you up titrate to 20 milligram if he was on 20. And if he was on 20 already, you just keep him on 20. If he's like potassium between 4.8 to 5.5, you keep him on the same dose, whatever he's taking, 10 or 20 milligram. If the potassium is above 5.5, like 5.6 and above, you hold the treatment, you repeat the potassium in a few days. When the potassium is less than 5, you restart with 10 milligram, and you do the same thing, the same titration.
Thank you very much. And I think just for the guidelines, because the time ran out, if you look at all the guidelines, it was always level A. In ADA, in every guideline you look at it, even European Society of Cardiology, of KDIGO, and so on. And I think if there is time for any question for Dr. Baher, we didn't address, please.
So just to emphasize that as a primary doctor, our job is here to start with the patient in the green area, in low risk of, yes, go ahead, doctor.
Can we use it only for microalbuminuria without CKD? Is it allowed to be used?
Without CKD? Yeah. As I say, like if the GFR is like 120 and you have microalbuminuria above 30, yes, you can use it. Because the recommendation by the guidelines, any number above 25 is allowed, as long as the patient has albuminuria more than 30.
Officially, it is covered by insurance in those cases?
Yes, I think, yes, it's covered. This is like drug.
Thank you.
Yes.
Any other question? I think one more question. Okay. So thank you, Dr. Baher. I know the topic is really need more time to address all the points, but I think hopefully we were able to at least know why we need to do this, and where we can put finerenone in it. And I think, again, just as a primary care physician, this is something really, as internists, our family practice and so on, should do this, and not just to wait till the patient go into the stage 3, 4 and refer. And in the case, as you said, A3 definitely needs referral right away. There is specific criteria for referral.
Yeah. So it's very important to choose your patient before you start and follow up with your patient and titrate up the dose. Thank you very much.
Thank you.